Welcome everyone to session 8. This is another multidisciplinary tumour board meeting, this one on PSMA Theranostics. We have an illustrious panel including Dr. Kerry Jewell, who's a PhD student with the Prostic team, and Dr. James Buteau, another Prostic PhD student. Louise Emmett, who needs no introduction.
PhD Prostic student.
You're welcome to join us. You're welcome to join us. It reminds me of when I did a fellowship in London. There's a Michael Hofman in Germany that did the first manuscript on gallium-68 generators, and he was like 30 years older than me, and someone called me up one day and was like, "Michael, why are you doing another fellowship?" Created quite a lot of confusion. We have Louise Kostos, another PhD student actually. We've got a very PhD-full panel, medical oncologist. And next to Louise, that's Liz Medhurst, nurse specialist Theranostics extraordinaire, and Associate Professor Arun Azad. For those who missed the previous session, it's Arun's birthday today, and he agreed to come in and do this. That is a mark of commitment.
I think we just need to wrangle ourselves a urologist. Yeah.
No multidisciplinary tumour board is complete without a urologist. Yes. Let me tell you, Declan jokes about us not turning up to his MDT on a Thursday morning, but let me tell you, there aren't too many urologists that rock up to our Theranostics meeting every week, but there are a few that come. We welcome them.
Maybe we should start getting breakfast.
So we have 8 cases to go through. We're going to have a spectrum of management issues from rather common to rather complex. Some of the complex ones are perhaps things that you should not do in your institution. We try to uncover some pearls and pitfalls, and really we have a multidisciplinary team, so we'll try to get some different perspectives from different team members. Louise, do you want to kick off with case number 1?
Excellent. So case number 1. So this is a 69-year-old with mCRPC pre-cabazitaxel. Has already had ADT, docetaxel, enzalutamide, and radiotherapy for pain control to the thoracic spine. He's got multifocal, so total body bony pain. He's got a problem with constipation, fatigue, weight loss. Eco 1 to 2 doesn't sound very comfortable. PSA is currently 64 micrograms per litre with a doubling time of a very rapid doubling time, 0.9 months, and he's been referred for consideration of next treatment, including potential of Lutetium-PSMA.
Louise, can I ask you, how do you do something really simple, how do you calculate your PSA doubling times?
You're asking Louise Emmett or Louise Kostos?
You're trying to duck the question.
Exactly what I'm trying to do while I think about the answer. How do I calculate my
Well, I've got to tell you, most referrals don't tell me the PSA doubling time. They just tell me what the current PSA is. They sometimes don't even tell me what the previous PSA is. And that's part of Liz's job, screening our referrals is, Liz, how do you calculate the doubling time?
There's a website that does it for you.
I was about to say that there's a website.
There's a phone app as well, which is very handy.
Yeah, there's an app from South America that I use for PSA doubling time and PSA density called PSA-PP. I can't remember which of our South American colleagues developed it. You did, Luke. No, you didn't. But it was definitely a South American urology trainee, I think. So we use that all the time, PSA-PP.
Yeah, I think we use the MSKCC website. It's very convenient and quick.
Yeah.
I think practically in clinic, the main thing we have to remember to do is reverse the day and month when we're putting our figures in, so that we don't get the wrong date in.
Correct.
Because we format them correctly in the day, the month, the year. Yeah. Hopefully that's the most controversial thing I say for the session.
So these are the imagings. We've got PSMA and FDG, just looking at that. And I might ask James, anything about the imaging?
Yeah.
Yeah.
So
Yeah,
All right.
we can do it together if you'd like, James.
Oh.
Sounds good.
Yeah.
It's the first time I see these.
Oh, good.
Yeah, there's a very high uptake PSMA PET scan to the left. Multiple bone metastases, a little lower uptake in the lumbar spine. Probably an SUV mean around 8, I'll guess.
What you're guessing? You're guessing 8?
I'll guess 8. I haven't.
Would you like to
just
know
keep
for sure?
rotating?
I don't know. Maybe 7.5. No discordance on the FDG. There's some mild.
He has had
Can
some
I ask you a
radiotherapy.
Can I ask a basic question? You've put the image like this, but why didn't you do it like that? Like why? Well, how do you choose how to window it?
Yeah, it looks much nicer.
Yeah, like some people, I think that looks better.
That's wrong. No. Look, I think when we window it for the SUV15, it gives it a really nice balance. So on the MIP for a visual assessment, we can easily pick out where our sites are and give some context to the intensity of the uptake. Practically, when we are reviewing these images in clinic, we might move it up or down a little bit to maybe pick up some subtle lesions we might not pick up if we were windowed for 15. But I think keeping a consistent SUV windowing and getting used to that is useful for repetition and seeing high volume cases, because you start to get a sense quite quickly for what you're looking at within a few seconds of seeing the image.
Yeah, so I think there is no standardisation here globally, but we like 0 to 15, so you'll see on the scale, so that means anything which is black is 15 or over.
Yeah, perfect. So again, in our MDM, we like to put the PSMA and FDG PET up together. We often have a couple of screens, so we won't necessarily have the fusion image of the transaxial through at the same time, but it just allows us to explain the case in the context of both images side by side. And so as we can see with this case, that we have a nice high PSMA uptake with no obvious discordance on the FDG PET.
And do you have the SUV mean?
Sorry, what was the...
Do you have the SUV mean?
Yeah, I do. So I can tell you for this PSMA PET CT that I will mention the volume for the PSMA PET, although that's not something that we're going to do for every case, but there's over a litre of molecular volume there. For the SUV max, we're 31.5, and for the mean, we're 6.5. When we look at the FDG PET, the volume there is 170 mils. The max is 7.5 at the sacral lesion, with an overall mean on the FDG of 3.7. But I guess, Michael, I've given the full gamut of stats for that case.
And I can tell you in my international travels, when I present some slides like this, I'm usually told, Michael, can you not talk about SUV means and volumes because we can't do them, so they're not of value to us.
Is there a visual way to quantify it? Louise?
There's actually 2 visual ways. One of them got accepted for publication this morning.
Congratulations.
So there's the visual PSG score, where you can actually use the parotid and the liver, and you can dictate whether more than 80% are above liver and parotid, and that's usually reasonably accurate. And we also have something called the HIT score, the heterogeneity intensity score, because one of the things that's quite interesting when you look at PSMA PET is sometimes there's really high variation. They might be suitable, but there can be a whole lot of variation between the intensity between the lesions, not just because of size. And in fact, that's a bit of an adverse prognostic reporter for response as well, and it's one of the reasons why people with quite high SUV max can also have quite low SUV mean. So, there's a number of ways you can do it.
So I think these quantitative measures are very useful, and you should try to find some software so that you can do it in your centre.
I agree.
All right. Do you want to
get on to...
Oh, there's a vote.
Yeah. So now that you've had the opportunity to have a look at those images and you're part of the MDT with us, what would you like to do with this patient? Would you like to watch and wait? Would you like to start Lutetium-PSMA? Any takers for chemotherapy or maybe some radiotherapy?
And while you're thinking about that, you're all going to be asking this question. I can let you know that the bloods look pretty good. The hemoglobin was 117, platelets a little bit low, 121, and kidney function, EGFR greater than 90.
Kerry, what about radium-223? Is that not an option for this patient?
Sorry, what was the...
Radium-223, bone-only progressive MC or PC?
Yep,
Have we all forgotten about radium-2? I mean, many countries are still available.
Nice if it was funded in Australia.
Yeah, and I guess I'm still in mindset of being the therapy fellow last year and having high volume, working things through quickly and knowing that radium's not an option to us at the moment outside a clinical trial, so probably having to dismiss it at this stage.
But very few people here are from Australia. They're up there from everywhere else. They probably have radium-223.
They probably do. But in Australia, it's $8,000 a month for radium.
But cost aside, would you put radium as a treatment option for this patient? If you had access to lutetium and radium and they were both available and reimbursed, would you consider radium?
Personally, I actually think Lutetium-PSMA in this kind of patient is an excellent a treatment option. If this patient didn't have a target, did not have a target, then I think radium's a good option. You don't need a target as long as you've got bright disease on the bone scan.
I guess one question, and anyone on the panel can have a look at this, I'm looking towards our medical oncologist as well. So we were talking about the SUV mean being 6.5 in this case. Do you think that affects our decision-making tree for how we look at this patient?
Yeah, definitely. So we're lucky, as Michael said, at Peter Mac, we get very lovely detailed PET reports with all of those parameters. And I guess in this case, my concern is the patient's symptomatic and they've got a rapid PSA doubling time. So we really want to make sure they get the most effective treatment next to get their disease under control. And we, I guess, mainly look at the SUV max, but the SUV mean is helpful for, I guess, giving some kind of indication as to how successful treatment with Lu-PSMA may be. So with an SUV mean less than 10, I'd be a bit worried they may not have a great response. Also, I think the FDG metabolic tumour volume is quite high, almost, I think it was 170, so they do have quite a large burden of disease. So for this patient, I think based on their imaging, I would be happy to treat them with Lu-PSMA, but at Peter Mac, we do have combination trials as well, so this would be someone we'd sort of be considering one of the combination trials for to try and give them the most aggressive treatment possible and enhance their response.
Yeah, sorry, Louise, I'll let you.
I was going to say, so we had the voting, and that was showing 88% of people would vote for recommending for Lutetium-PSMA, 11% for cabazitaxel and 2% for watch and wait. So I think that's reasonable.
Yeah. I think Louise raised a really interesting point, and if we go back to the main presentation, actually we were very fortunate to put this patient on the LuCab trial, and if we click one more over, we'll see a summary of their post-therapy SPECT-CTs from their first 5 cycles, and we can see that this patient's having a really nice response. In addition to our post-therapy imaging, I can tell you that the PSA peaked at 65 prior to the first cycle and is down now to 1.9, so a greater than 99% response rate there.
So the question I've got, peaked, so the PSA actually went up a little bit before it went down. That's something you see commonly?
I think, Louise is looking at a lovely little PSA graph in front of her, but I think the peak was just prior to the first cycle, and if I've not annotated that well, I apologise.
Okay.
But it's a good question,
Yes.
and it's a common question we get asked, is there a PSA flare that occurs after Lutetium-PSMA? It's a question for you, Louise.
I know, certainly with the LuCab trial, we do put patients with more aggressive disease on that trial. So often the PSA does actually go up, sometimes for the first 3 weeks or even the first cycle before it comes down again.
So I'm not sure that we see a flare after Lutetium-PSMA therapy. I don't think that actually happens. A flare meaning release. I think sometimes the PSA trajectory is just so fast. If you've got a doubling time of 0.5 months, it's going up so fast that it takes some time to plateau before it goes down.
It's almost like it's doing that, isn't
Correct.
it?
What about pain flare, Michael? I've seen that a couple of times. Pain flare after lutetium. You know, so I think there is a clinical flare. I mean,
that's a real problem.
Yeah. Yeah.
And that was certainly a consideration in this case. This patient, construction worker, and was on opioid analgesia, having a lot of trouble with pain, and I believe had a little bit more pain after the first cycle or 2, but subsequently feeling much improved now and getting back to some social hobbies that he was involved in prior to becoming unwell.
I think when the patients do have a flare of pain they call Liz up, actually. What do you do, Liz, when they do that?
Usually speak to my medical oncologist, but usually it also helps us with planning for the second cycle. So if they have a pain flare with cycle 1, usually we can discuss whether we give some Dex as a pre-med for the second cycle just to try and combat it.
And if we're talking about high volume patients in that first injection, they get a pain flare in a significant percentage of patients with high volume disease, and I pre-warn them of that if they've got high volume. The other flare they get is severe fatigue. So those high volume patients are particularly at risk of quite severe fatigue in that first 6 weeks, and they really need babying through. I don't know if you noticed that.
Yeah, the fatigue can, I guess in my experience, usually, especially if they're really high volume and they have a really big PSA drop, and especially in that first kind of 3 weeks, the fatigue can be quite profound before they start to feel better. And then they get a bit worried about having the second cycle because they don't want to feel as bad as they did the first. But I think it's just the initial kind of response that we see.
I'm sure it must be something to do with release of, tumour necrosis factors and interleukins. If you've got a massive cell turnover happening there.
We do need to get through 7 or 8 cases, but there are 2 questions in Slido, anonymous questions. Given the lack of OS benefit, would that impact your sequencing decision? So I think what someone's getting at is why not give carbazitaxel rather than lutetium in this patient? Arun, do you have a comment on sequencing? What would you suggest for this patient?
Yeah, I mean, I think that if this patient was appropriate to treat with lutetium. I think, yesterday we were talking about this. I think the key is to try and get as many of these treatments into patients as possible. I think that going with lutetium is good in this patient, but perhaps potentially, if you were just giving lutetium alone, given the SUV mean is a little lower, I would definitely counsel them about the fact that, carbazitaxel is next, and we shouldn't, leave that on the table if at all possible. Look, in the end, carbazitaxel has a survival benefit, but that was against mitoxantrone. It's old data. We don't use mitoxantrone anymore. You can argue about the design of, the control arms from the VISION trial versus therapy, but I think they're both active and life-prolonging agents, and if we can get both in, it's more important than the sequence, to be honest.
But I think there's 2 things that ultimately matter, and it's not survival's one of them, and the other one is quality of life. And in the therapy trial, we showed unequivocally that there was a very strong, favourable outcome for patient experience. So symptoms with improvement with lutetium compared to carbazitaxel. So that's why we recommend lutetium prior to carbazitaxel. Case 2, 71-year-old with who's post-carbazitaxel. Has also had abiraterone, radiotherapy to the prostate, docetaxel, ADT, and most recently olaparib. So really has had the whole kitchen sink, and now has a right nephrostomy due to extrinsic compression with a EGFR of 70, which is okay. Widespread pain on opioids, fatigue, weight loss, 15 kilograms, ECOG, PSA 60 with a doubling time of 1.5 months. And referred for consideration of Lutetium-PSMA versus best supportive care with no other treatment options available. I think we've done would you even do a scan? Is this patient too sick, or should we do a scan? We've done a scan, so maybe we can look at the PSMA and FDG.
So we can see here, Michael might get you to spin the images for us. So again, we've got a FDG PET that's been done on the 28th of February, and we're comparing that to the PSMA PET that was done on the 1st of March. And I think that's important just to note that one of the first things I do when I'm looking at these images is just see how close the dates are together, because that can affect our interpretation of what we're seeing. But in this case, the FDG PET was done first. So yes, as we can see that moving through, I'll just take you through the transaxial slices. So we're going to move up and down. We have quite widespread nodal, bulky nodal disease on both sides of the diaphragm, with mediastinal and cervical node involvement. And then we come back down to the liver, and we can see bilobar bulky lesions there as well. And coming down, we can see why that nephrostomy has been placed. We have an atrophic kidney on the left-hand side, and our line in situ on the right. And clearly, so this is quite symptomatic, burdensome disease.
So we have a few statistics. The SUV max was 55, the mean was 11, and the MTV on the FDG was 2 litres. That's a lot of disease. Hepatic metastases, Louise. Some of the literature suggests that patients with hepatic metastases don't do well with lutetium. I see some clinical trials coming in from industry where they exclude patients with hepatic metastases. What are your thoughts on, should we just say this patient's not suitable because there's liver mets?
This man's up against a wall, isn't he? I mean, what's he got? So you can say, I'm sorry, you're not going to do very well. There's a chance you might not do very well with Lutetium-PSMA, but that means we're going to send you home to die, essentially. So he'll do better than nothing. So I definitely think that you should offer him this. Also, the disease in the liver is pretty bright. I mean, it's equivalent to everything else. I would be looking very carefully to make sure there's no mismatch, but just looking on this and looking at previous images, it doesn't look like there is. Potentially he's got an SUV mean of 10.8. That's in an excellent category. I've had some excellent responses with liver, and I would go for it.
Yeah, I agree. So my experience is that most patients with liver metastases have much lower uptake on the PSMA, and that we know correlates with lower response rate, but this patient's got super high uptake in the liver metastases, so I'll be quite confident that they will actually respond well. Should we treat this patient? Oh, I think we've answered that question. Anyone on the panel not want to treat this patient with lutetium or have another option that no one's considered?
Well, it's definitely a conversation to do nothing because this is not a funded treatment. So for the vast majority of patients in this country, that'll be a $10,000 option to have 1 cycle of lutetium. So it very much depends, Liz, on the patient's circumstances. It's fine if you're at Peter Mac, you'll get it covered as part of the registry, the PCF Prostic registry. But Liz, for a lot of patients, it's directly, this will be a $10,000 thing. Would you prefer to keep that for your family?
$6,000 at St Vincent's, and we do
like a
compassionate
hotel room in
and people
Sydney,
can't afford it.
I guess my question was, when
For
are
most
they too
patients in the
sick
country.
to have treatment, Louise? Because this guy sounds really sick. He's ECOG 3, at some point, yes, the images look good, but are we doing a more burdensome of bringing him into the hospital for 2 visits on the off chance that we might, hopefully, I guess we always aim to improve their quality of life, but, is there such a thing as too sick?
Yeah, I think that's a really good point. I mean, if we were considering chemotherapy rather than Lutetium-PSMA, we wouldn't normally treat a patient who's ECOG 3. And with that burden of liver disease, this patient, has a lot of strife and has a very poor prognosis. But I guess if we think about the goals of treatment, yes, prolonging survival is one, but also providing palliation and improving quality of life is the other one. And even if we don't impact this patient's survival, if he's in such severe pain, he's on opioids, he's losing weight, giving Lu-PSMA may even just improve his final weeks of life.
Arun, would you refer this patient to a radiation oncologist? There's a question about should we give radiotherapy to the liver mets in conjunction with Lutetium-PSMA?
No, I don't think I would do that, Michael. I think it'd be too toxic, to be honest. I think, this guy, I think I've had patients like this where you discuss options and in some cases have refused lutetium. They've just had enough, and you can't say that they've had every life-prolonging therapy, or just about every life-prolonging therapy. So I think lutetium, here would be very much, you'd want to be minimising treatment toxicity given his ECOG 3. So lutetium would be well tolerated in a lot of cases. It's reasonable to give.
And Louise, you're the queen of enzalutamide upregulation. There's a question on that. Should we quickly start some enzalutamide before we do the lutetium therapy, since it's going to take 2 weeks to order the lutetium?
Well, actually, to tell the truth, this guy needs lutetium tomorrow, so I would be trying to fit him in as quickly as possible. That's much more important than starting the enzalutamide. It's got an SUV mean of 11.
Yep.
So schnell, Annabelle, inject.
Cool. Great. And there's a question there about MTVs. And we have looked at this, we've looked at all the SUV maxes, means, volumes in quite some detail some years ago, and we've identified volume on the FDG and SUV mean on the PSMA as the 2 most predictive or prognostic, and many publications have now replicated those findings. So we don't use MTV on the PSMA as a predictive or prognostic biomarker, but we use the SUV mean, and the vision data not published, but presented by Ken Herman and Philip Kuo at conferences, supports that as well.
I might just have a question for Liz. If we're coming out of MDM and the medical team is telling you we need to treat this patient sort of in less than 7 days and we've not got any spare doses, practically how would the team deal with that?
We have a wonderful team at Peter Mac, and we usually can, in extreme cases, we can usually fit people in, or if we have to shuffle things around, we kind of have to prioritise patients as they come in. We do have like our own prioritisation scores that we use to kind of guide us in the MDM normally, and that kind of takes into account of everything that we've discussed at the moment. But you know, I think we try and get urgent patients treated quickly.
So we did prioritise this patient, but it still took a little bit of time, and over that time his GFR fell from 70 to 58 to 47 with a nephrostomy. Declan, does that drop in GFR concern you with the nephrostomy?
That's cycle 4, Michael.
Oh, that's cycle... Oh, you're right.
He's had 3 cycles.
Goodness
and
me.
He's turned up for his 4th cycle. It's the day of treatment.
Goodness
and we just
me.
happened to be checking his bloods and noticed that
What happened with the first 3 cycles?
Yeah, he did really well. I remember him quite nicely. He was doing remarkably well. His life changed after 1 cycle. Lots of energy. He had moved across. Actually, he had moved also near the beach. And I remember him quite well because we have our urology colleagues. We were looking at this scan, dropping EGFR, and then we looked back on a scan that had been done, and you see the nephrostomy that was slowly coming out.
Yep.
Always good to have urologists close by, give them some coffee, try to work them up, and they come down in nuclear medicine actually, and they give a hand. So he had a nephrostomy put in. He didn't have any pain, any infection, but they did reassess him, put in nephrostomy over the weekend.
Yeah, it's usually just a plumbing thing, single kidney nephrostomy dependent situation. It's usually just a plumbing issue. It's blocked. We flush them. They get a bit of hematuria sometimes, and normally we'll find out quickly because if they're nephrostomy dependent, all the urine's coming out in the bag, and the patient will say, "My urine output's been dropping off for a couple of days." So they're usually pretty aware, and we'll get a heads up often before we see bloods dropping like that.
So looking at those notes, they've gone down quite a bit.
Yeah.
Aren't you going to try and stent them?
Absolutely. Well, yeah, or trial of clamping the nephrostomy. Sometimes they'll drain. Sometimes they'll drain down.
I guess obviously not this time.
Yeah, not this time.
Yeah, so this is what happened to him. You can see his PSA was going up quickly, came down very nicely with 6 cycles, and these are his bloods. We have some great software that does exactly these graphs automatically as part of our registry. So we get some beautiful graphs, and you can see his hemoglobin, platelets, neutrophils are pretty stable. EGFR came up after the nephrostomy was replaced, and his other bloods are doing pretty well. That's a pretty incredible outcome with a PSA of 0.5 post-treatment with liver mets and everything else.
The point I would make is this guy was in trouble when he turned up, and so you don't sit there and think about it for a while. You get that injection straight in. You get the earliest possible dose.
Mm. Yeah, so I think here are the teaching points. Visceral metastases are not always bad. We've got several patients. These are not that common because this high uptake in liver mets is not typical, but when you do see it, you can know that patients may get great benefit. Benefits of post-therapy imaging, we picked up the pending obstruction in line with the dropping EGFR. And here's a picture of his post-therapy SPECT CTs.
Yeah, I think an important part also is just like having a good nurse consultant also. Like I remember we had been flagged, 3 weeks post quite quickly. We have to act, book in the patient, have a proper review, get urology involved. So you have to act very proactively in these cases.
Louise, you're doing case 3.
So a 65-year-old man, MCRPC post-cabazitaxel, so also very late, had previously been treated with a radical prostatectomy, hormone therapy, enzalutamide, docetaxel, and cabazitaxel for 16 cycles, so a lot of cycles. Presents with severe bony pain and left hip fracture, currently on opioids, lethargy, cachexia, so very end-stage symptoms. ECOG 3, PSA 1,696 with a very rapid doubling time. Entering marrow failure, I'm assuming, unless it's residual from the cabazitaxel, hemoglobin of 81, white cells 4.6, and platelets 278. Considered for lutetium. Ooh. It's high volume day.
It is. It's should we treat this patient day?
Is that
I
a
think
bone scan?
it almost looks like it. I guess we could say super scan, right? You can see very extensive bone marrow involvement. I don't know how highly avid it is. We'll have the stats after, but SUV max is probably around the 20, 30, maybe 40 range. You can kind of wind it down. I like to do this and play where's the hot spot. So you can kind of bring it down, and I guess it's probably this, 35. And when you have a look, you can play around with SUV max, up to 15, 30. I think he's probably in that lower quartile as well. I'd say below 7. The very high FDG uptake, very bulky nodes as well. So he's extensive disease. I guess the question is, should we be treating with so much and so low uptake?
Have you got some questions on this one?
I think he's got a liver metastasis hiding in there too. Yes, there is.
Yeah, right there.
Hiding there,
The
small little
issue-
liver metastasis.
Eyes of an eagle.
You've got to see that on the spinning image.
So the issue with this patient is they've got very high volume disease. They've got concordant disease, but it's pretty bright on the FDG, so their volume on FDG is going to be very high as well. And it's bright disease, but it's not particularly bright, is it?
So I should just say that I did not word James up on the stats for these cases. So he is picking these figures off the top of his head, and he's done actually pretty well.
Second lowest quartile, but close to the
Yeah,
lowest.
and I will take my bribe after
Yeah.
to talk you up.
Yeah, so there is statistics. I won't go through them in any detail, but clearly above liver, above parotid gland, SUV max 35 would meet lutetium by any criteria. No discordance. I guess, should we treat him with lutetium or should we do best supportive care? I think to answer that question, you need a bit more history that we haven't told you, comorbidities, social history, etc. We're told that he actually speaks and not, comes from another country, doesn't speak much English, but he is independent. He's got a lot of left hip pain, and he's sleeping about 4 to 5 hours at night because of the pain, and then he sleeps about 2 hours during the day. So his ECOG's about 2.
I was present for this initial consult, and it was conducted by a telehealth with the patient in bed. This happens rarely, but it's just a sort of an unofficial poor prognostic sign that if we have a patient that's not able to get out of bed for the consult, that's just something that we note.
You think that ECOG2 might be an underestimation?
Yeah, I think so.
Okay, he's changed to ECOG 3.
Yeah.
And do we want to treat this patient, Arun?
I think it's reasonable to do. Yeah, I mean, again, at this point in time, anything other than lutetium probably is going to be too toxic. Patient's performance status won't allow it. So I think for palliative reasons, it's reasonable to do. So I would offer it. But again, he's had, a lot of treatment. 16 cycles of cabazitaxel.
Mm-hmm.
So again, if he didn't want it or there's reluctance, I wouldn't twist his arm because he's had a lot of treatment. And so for some patients won't want treatment here, but I think it's very reasonable to offer it to him.
Yeah, I think that my main concern would be whether Lutetium-PSMA would cause very significant cytopenias, because he really ticks all the risk factors. He's heavily pre-treated with taxanes, he's got diffuse marrow disease, and he's got baseline cytopenias. So making sure the patient's very well informed that it could cause significant toxicity.
And as queen of starting someone on an ARSI, if it's needed, this would be a patient who I would think that it's needed if we can get hold of it at all at a compassionate level. So if they've got some left over, then this is the patient that I would want to be value adding in terms of upregulation and hitting as much as possible.
So we did treat him, and he developed some anemia that required blood transfusions. We dose reduced for cycle 2 and 3 as a consequence of that, and his symptoms improved greatly. He had reduced pain, reduced opioids, more clear thinking. He was actually able to go camping with his grandchildren for a long weekend, which was a pretty good outcome. But he had clinical progression post cycle 3 with rising PSA despite that second cycle or third cycle of lutetium. and at that time a decision was made for best supportive care, and he passed away 3 months later.
Michael, can I just ask you about the anemia? So when this patient arrived to us, the hemoglobin was 81, and in the 2 weeks it took us to book him in for treatment, and it dropped to 58. Now, we were able to arrange transfusions concurrently with the referring medical oncologist at the time, but just speaking on that anemia and looking at the scans, how's that factor into when we're putting these patients up for lutetium?
Yeah, I'm not too worried about anemia because blood transfusion is a fairly easy intervention. I'm more worried by thrombocytopenia, and his platelets were normal at baseline, so that was actually very encouraging. But if his platelets were below 100 before we started, I think this is someone I would categorically not treat. I think we're more likely just to cause a profound thrombocytopenia and have very limited benefit, but anemia is manageable.
Just one comment. I think we underestimate how good Lutetium-PSMA is at controlling bone pain. Like, it's actually exceptionally good. And to make the comment about the palcare physicians, this guy was already heavily linked into palcare, and he was on quite high dose, long and short acting analgesia before he came to see us, and we were able to dramatically drop that off, which was great after one cycle, but it is wonderful for bone pain in these patients.
Yeah, so I think there's a question there about palliative care physicians. I think that's really important. And how do we dose reduce based on kidney dysfunction? Well, this patient didn't have kidney dysfunction. Look, we generally don't dose reduce just based on GFR, but we will dose reduce by 20% or 25% if there's a platelet and a DR less than 100 between cycles, or if hemoglobin drops below 80. Here's a graph of his PSA, so you can see it sort of did go up after cycle 1 and then declined a little bit, and there are his bloods. He did get a thrombocytopenia after cycle 3 down to 50.
Just looking at the question too about assessing mobility. So whenever we see someone for an initial consult, there's a full functional assessment that's taken, and independence with toileting, dressing is taken into account with each assessment that we do. In terms of the radiation safety implications, that's something that we work through with our nurse specialists and technologists as well. If we have complex toileting needs, then we have a radiation safety plan in place prior to their first cycle.
How does that work in practice if he's bedbound with a nappy? Is it doable?
I think there's a couple of things being bedbound with a nappy. Yeah. It's a radiation dose to the staff. Is a radiation dose to carers, and that I think is one of the contraindications, relative contraindications for Lutetium-PSMA therapy. You know, our staff aren't more radiation resistant than everyone else on the planet, and I do think we need to think about that a little bit, in my opinion.
Because it may well be that reflects the performance status, but sometimes these patients can have, actually reasonable other parameters, but it's just the toileting issue. That's why it's a great question. Might be the thing that says, well, we think you're suitable, and actually probably we will get a meaningful response, but there may actually be a contraindication just from a radiation safety point of view. Never thought about it. Yeah.
And just the question on dexamethasone, yes, we do consider it if there's a high burden of disease, or we suspect a disease pattern that's likely to cause some flare symptoms. And this patient received 8 milligrams on the day of treatment and for 2 days afterwards. And I think for him we did that for the first 2 cycles, but by cycle 3 it wasn't needed.
Some patients with very high volume disease who get that crippling fatigue in the first dose, we actually continue a low dose of steroid for the 2 weeks. If we get, they can bounce, so they can get the 844 of the dexamethasone in high volume disease, and they call you and they say, oh my God, I'm feeling terrible. Or when we do a routine call, which is the next week, and we put those patients back on some steroid for a couple of weeks, and it makes a massive difference to that initial severe fatigue and bone pain that they can get for up to a good week.
Arun, would you consider GCSF for this patient after cycle 3? So the platelets have dropped to 50, the neutrophils are 1.1, and the hemoglobin is 87.
Yeah, I mean, it wouldn't help the thrombocytopenia. I think this guy's declaring himself. I don't think I'd give him GCSF in this situation. I think unfortunately his disease, it's a combination of disease and maybe some toxicity, but I think that he's declaring himself. I don't think GCSF would help.
We have published this paper in European Urology where we looked at quite a lot of patients who had PSMA superscans or diffuse bone marrow involvement together with our German colleagues. And, we showed that the rates of G3, 4 or 4 thrombocytopenia was significantly higher in this population, but treatment was still deliverable. Case 4. I think we've got another superscan case before we move on from this theme.
It's a theme for the year. 78-year-old male MCRPC post-cabazitaxel again, so extensive treatment. Radical prostatectomy, ADT with radiotherapy to multifocal bone lesions. Greater than 80 sessions. Is that a record? Oh my goodness. Docetaxel, abiraterone and cabazitaxel. Has minor lower back pain and leg pain to the few sites that haven't had radiotherapy. ECOG 1, walking dog for an hour most days. PSA 500, doubling time 2 months. Counts look okay. Hemoglobin 112, white cell count 4, platelets 175, so mildly anemic.
All right, so we'll press play on this, and so again we've got a PSMA PET scan on the left and our FDG on the right, and they're very close in dates together, but again we see this diffuse bony involvement. There are some nodes hidden there as well, and then if we come back up, bringing you back up towards the liver, there was just a very subtle liver lesion there as well that's not showing up particularly well.
I think we should do the James Buteau SUV mean.
In the game?
Yeah, the game.
The game, all right. What do you feel, James?
Well, yeah, what I do like to do, this is 15, then you kind of wind it down. Oh. Yeah,
is there any
15
technique
is
to this
good.
that you would like to share with the audience? Like, do you hold your tongue in a specific way, or?
No, I just go like a lot, and then the number comes to me. Yeah.
And what are you divining at the moment?
Well, I think I do like to flip it when you see it's windowed 1 to 15 and 0 to 15, and you flick to 0 to 30, and if you kind of see the same thing with very, very dark spots, like it's almost certainly going to be SUV max mean above 10. I think in this case it is not 10. It's probably, I'll say 8.5.
Not 0.4 or?
He's 54, yeah, 8.5 to 9. I don't know if I'm allowed a little bit of a wiggle room. Yeah.
So let's move on. What was it?
It was SUV mean was 7.7.
Oh.
SUV
Out.
max
Slipping.
35.2, and he had yeah. So what's our next management step? Watch and wait. Trial of lutetium, carbazitaxel re-challenge, or radiotherapy to painful bone metastases.
Radiotherapy's certainly been a popular previous choice, hasn't it?
Should we go for 81 or?
Seems most people are going with lutetium. So he was treated with a cycle of lutetium, and you can see his PSA did go down quite nicely after cycle 1. His platelets, however, also dropped even more sharply than his PSA. His platelets there have dropped to 23, or 33 rather, at 4 weeks. So we need to make a decision now whether to order cycle 2 dose. So we've called up
Well,
Arun.
Liz has called up too, has spoken to the patient. Liz, what were you hearing from the patient?
I believe he was in hospital at that time because he had actually been admitted with pneumonia on top of the dropping platelets as well. So he was admitted about 2 to 3 weeks after his first treatment.
So did he have DIC from sepsis?
I actually remember this one. It's just before you spoke with him. This was like a Friday afternoon call, 4 or 5 o'clock, and he was feeling unwell, and I think we just had the 3-week bloods that were delayed, and that's it. We directed him to hospital because he wasn't. That's it. He was just feeling very off, very tired, lethargic, and he lived like 4 hours away in rural Australia, quite far. So we had sent him back, and he did have quite.
We had a patient on therapy, actually, Michael, whose platelets went down really dramatically after the first injection. He thought, wow, they must be in full of bone disease. It was hard to explain. And he ended up with osteomyelitis and DIC related to sepsis, and that was the cause of his low platelets. So my question to you is it entirely from the injection?
Well, in this case, he was admitted to ICU with pancytopenia, febrile neutropenia, which is a bit unusual, complicated by pneumonia. He was given antibiotics, infusions. He was in hospital for a month. He had some radiotherapy for spinal cord compression. This is not a very good course after cycle number 1. But he did recover after some time. 4 months later, after cycle 1, his hemoglobin was 96, platelets came up to 138. And the question was, should we give him cycle 2 of Lutetium-PSMA? Louise Kostos, do you want to give him cycle 2?
I think I'd be very reluctant. I think this case compared to the previous one, I guess it sounds like the patient was much fitter. They were ECOG 1 and he was still walking the dog each day. But was also still very heavily pre-treated with all of that radiation, plus he'd had 2 taxanes. So he was always going to be high risk for significant cytopenias. But when his functional status is quite good with not a huge symptom burden, I guess the risk-benefit ratio of giving Lu-PSMA is a little different. So I think given he had such a significant complication after the first cycle, I wouldn't risk giving him a second one.
It's an interesting question though, isn't it? The previous radiotherapy, you don't normally hear about people having quite so much radiotherapy to so many sites, and I wonder how much that does impact whether or not they're going to get marrow toxicity. Have you looked at that?
Yeah, I don't think we've looked at that, no. We have a question from the audience.
For Epigen or Neupogen or any of these marrow stimulating products in managing patients between cycles or in prepping patients for lutetium?
Yeah, that's a really good question. It's not something we do as standard practice in Australia. And interestingly, I think we were having this discussion last week. Neutropenia has been documented after treatment with Lutetium-PSMA, but I don't think febrile neutropenia is very common at all. This patient obviously had sepsis, but I'm not sure if it was febrile neutropenia. So we don't get too concerned about neutropenia. It's more the thrombocytopenia, which is a big problem. And the anemia we can manage quite well with blood transfusion, so we wouldn't normally give GCSF. What do you think, Arun?
Yeah, I don't think there's any role. I mean, it's different to chemotherapy. Neutropenia is not usually a major problem. The thrombocytopenia is not going to respond to those treatments. So, and look, the marrow stimulators, have their own toxicity, bone pain particularly. So these patients often already with substantial pain, so we don't give them typically.
Yeah, I think these are challenging questions. If you just look at the numbers, I think it may be reasonable to say let's proceed with cycle 2. That's what I would do, just based on those numbers. I think he's made a recovery. So this really is a discussion with the patient, and the situation here was that he lived actually a 6-hour drive away from the hospital. So this just changes the dynamics a lot. He wasn't very happy with his time in the ICU. He was kind of reaching end of life. So I think it's a discussion with the patient, and after that the decision was made not to proceed with cycle 2, and he passed away 2 months later. There's a question there about approach with cord compression in a patient with potential cord compression who will benefit from Lutetium-PSMA. Declan, can you pretend to be a neurosurgeon rather than a urosurgeon and tell us what to do in this situation?
I don't know what the data is for Lutetium-PSMA in impending cord compression, because we know radiotherapy and surgical stabilization are very effective and can ward off like a dreadful, end for these poor patients. So I have no idea. Well, it's such a disaster when you end up with this flaccid paralysis from a cord compression. that we'd want to be very confident if it was an impending core. But I don't know, because Lutetium-PSMA is so well tolerated, you can get it quickly, but normally radiotherapy and neurosurgery we can get very quickly.
Do you ever get phone calls at 2 a.m. when they confuse you as a urologist and neurologist? They sound similar. Do you ever get phone calls to deal with the cord compression?
They don't call neurologists about core compression. Neurologists only work 9 to 5. It's neurosurgeons, Michael. Yeah. So no. Therefore, urologists never get phone calls out of our about neurologists. I get lots of emails though. There's a Professor Declan G. Murphy, neurologist at King's College in London, and he and I get a lot of cross communication. He's an expert in autism spectrum disorder. So they're the confusions I experience in my email. He must get a lot of crap about prostate cancer, I'm sure, as well.
But I think as a general rule, we like to deal with the cord compression before proceeding with lutetium. So that's either neurosurgery and or radiation as appropriate. So if there's pending cord compression, we would deal with that first.
Pending cord compression, if you have just circulating, if the cord is just encircled and you think they may be getting it at some stage in the future, I think it's fine to go ahead with the lutetium.
Yes, I think you've got to differentiate this just from an imaging finding. There's a great study of MRI, screening MRIs in metastatic prostate cancer published in The Lancet a couple of years ago, showing actually a really high incidence of incidental pending cord compression on MRIs that were not clinically significant when they followed these patients up in a randomised design.
I think it's also important to note most clinical trials will have an exclusion criteria for impending spinal cord compression, so we probably won't ever have trial data showing the response of Lu-PSMA for spinal cord compression.
And just to say, in this case, we didn't repeat the PET scans. We didn't think it would change our management. And again, it was a logistics question as well, with him being so far away from Melbourne, whether we really wanted to put him through the travel to a PET centre to get something that wasn't going to probably change things.
Case number 5, 67-year-old, so a young patient, post-carbazitaxel, who's also had docetaxel enzalutamide radiotherapy to the spine. Bone pain is controlled on multiple opioids. He's got ECOG 1 to 2, PSA 430, doubling time of 0.6 months, referred for suitability for lutetium therapy, and we've done a PSMA and also an FDG, as we always do.
All right. So we'll just we'll start these MIP images going again and have a little bit of a look. So the impression that we're getting straight away here is that the overall PSMA activity is quite heterogeneous. In fact, I can tell you that the SUV max here is 13.8 and the SUV mean is 4.8. And then when we come down on the FDG PET towards the pelvis, we can see these multifocal avidities that when you go through carefully, you can see that there is some spatial discordance where the extent of FDG activity is probably a little bit more than what we see on the PSMA PET.
Can we just window that image out a little bit, because that's windowed quite heavily. So I think this is actually that's the dotatate. This is the PSMA windowing, so you can see that the uptake is kind of less than parotid in the majority of locations. So I think you probably had it over windowed to start with, and you can give a false impression that it's intense uptake, but it's actually quite low intensity uptake. And then if you look closely, you do see sites like this rib. Oh no, that's not a rib. There are some bone sites that have more FDG uptake, like here, than the PSMA PET scan.
Yeah, I was about to say it doesn't look like SUV mean of 4.7 on the previous one, so I think like windowing, that's a really good point. You'd really have to standardize these.
Just trying to catch out.
Yeah, no, it's confused.
Testing the limits of your
This
skill.
has got to be the wrong patient.
See, I mean, obviously this candidate's not ideal, right? But they're post-carbazitaxel. I'm assuming they don't have a DNA damage repair. They're not suitable for olaparib or another option.
Yeah, I think this is a complex decision. Again, it depends upon cost, availability, social factors, comorbidities, everything else. It's not a imaging or SUV criteria. I think this patient had a difficult social situation and lived quite a few hours drive from the city, and was we had a cancellation actually a day later, so we had an opportunity to treat this patient quickly, and the person seeing the doctor seeing the patient thought, this is great, let's book him in, and it was discussed at the MDT, but it was already booked in for the next day. And I was actually a bit reluctant to treat this patient because the low SUV mean really worried me, the quick decision making, the long drive, I think the patient had some social isolation. I was a bit concerned.
Yeah, it's not optimal.
Not optimal. We did treat the patient, and despite the suboptimal imaging phenotype, but we had a dose available, and I actually remember he was treated on a Thursday, and then at Friday at 5 p.m. I got a phone call from a patient's relative who was very upset because the patient had come down to Melbourne through transport, and we do this as an outpatient treatment, but accommodation was arranged for this patient nearby to Peter Mac, and post-therapy the patient was very unwell, couldn't get out of bed, and the relative was like, what do you mean? You didn't admit this patient? There's no nurse looking after him? You've just treated him and there's no nurse? Like, what were you thinking? This is unconscionable. There should be a nurse with him 24/7. If we had known that he wouldn't be looked after afterwards, we wouldn't have sent him down to Melbourne for treatment. So it was quite an angry call on a Friday afternoon. And after the first dose, his PSA continued to rise, and he was admitted for local palliative care and pain management support, and he had some delirium, worsening symptomatic anemia, malnutrition, and I think he passed away very soon after that.
Did the patient want treatment?
Sorry?
Did the patient want treatment?
The patient wanted treatment, yes.
I think, though, this is one of those cases that highlights the power of the in-person review. So when we saw him for his post-therapy review, one, we could see how cachectic he was. And I think you have that sense when you look at that sort of patient that their time is shortening, and they might not only have weeks anyway. And there's also the subtle body language cues that you pick up on. So we began to get the sense that perhaps he hadn't accepted treatment for himself, but for others in his life. And I think that's the sort of nuance that you get in an in-person review that you don't necessarily see via telehealth, and certainly not via telephone if we can't hook up with telehealth, which is a consideration because often we book many of these patients in for telehealth, but when it comes to the appointment time, they might not be able to get their technology to work, and then we have to make a decision whether we try to consult them via the phone to get things moving, or if we try to rebook, which can cause delays.
Look, I think we have to be careful not to oversell the treatment and just inform the patient honestly. So if this patient had super high SUVs, I'd be very keen to treat him, but with an SUV that barely reaches 15, wouldn't be suitable for the therapy trial. I'm hesitant to treat him. I still may give him the option, but I'll be honest and tell him, look, it's not likely to help you, and it does have side effects. You may be worse after this treatment. You may have fatigue, you may have nausea, and it may not benefit you, and you may be symptomatically worse. And if the patient's still keen for treatment despite informed consent, it's quite reasonable, but too many people are just overselling it as a treatment without side effects. There's no downside in having treatments. Come try it, but there is a downside. I think this patient, had a miserable last few weeks of life as a consequence.
Sometimes it's very difficult for people to accept that there are no treatments, and we can't say that this patient definitely won't have any response. Do you think it's a bad thing to give someone that option of treating them?
Yeah, it's a complex discussion because some patients can't accept, or their families can't accept when they're reaching the end. I mean, I think part of the discussion I'd have with the patient here is if you look at the dates, we don't know what the month of some of these treatments was, but he had castration resistance within 12 months. That's a very poor prognostic sign, and he's cycled through docetaxel, enzalutamide and cabazitaxel in less than 2 years. I would actually say that even if it had a higher, a more favourable PET phenotype, that his duration response would have still been low. He might have responded and improved quality of life and had symptoms, but I don't think this patient would have had long survival typically, even with better PET, or different PET phenotype. So, that's part of the discussion you have with these patients is, look, your cancer's gone from cancer's just been rapidly progressing despite all these treatments over less than 2 years. it's time to, I mean, I think, whether or not you give lutetium, he's not going to do well, and I think that's part of the discussion you have to have at this stage.
Yeah.
Case number 6.
So, case number 6, an 86-year-old man, MCRPC, already had 9 doses of Lutetium-PSMA, 6 of them on the therapy trial, and then a subsequent 2 treatment blocks, which were ceased after C4. Something was ceased after C4 due to thrombocythemia. It must have been during the therapy trial, is that right? But also excellent response. Is that what happened?
Yeah.
Okay, and then re-referred for consideration of further Lutetium-PSMA, 4 years and 11 months since the first Lutetium-PSMA dose. PSA doubling time 2.5 months.
This is a bit of a summary. Looks like a complicated case. So he had 4 cycles on the therapy trial, and then 4th cycle was dose reduced, and then 3 years later he had 2 more treatments, so he did very well. And then had another 3 treatments. Maybe we'll have a look at the imaging to try to work out what's
Did he stop on the
happening
therapy trial for exceptional response? Is that why he stopped? Or was
I think it was convenient that his platelets had dipped, but also he was doing really well.
So they stopped, and then
Yeah.
so 2 of those extra ones were recommencing on therapy
Yeah.
after exceptional response. Fine.
Yeah, if we switch to the imaging, we can see Kerry take us through.
Yeah, so we've got a number of scans here. So we can say starting in May of 2018, this was the baseline PSMA PET and paired FDG that were completed before his first cycle of lutetium PSMA. Coming over to August 2022.
So just at baseline, is that just in the lymph nodes, or is it in bone as well?
It's node predominant. I think there were a couple of subtle bony lesions, but the majority is nodal disease, and we can see that particularly bulky in the retroperitoneal station.
So what I think, the common knowledge is that the thrombocytopenia is due to crossfire to normal marrow, and this guy has node-only disease. Louise, why did he get such a marked thrombocytopenia after lutetium?
Yeah, sorry, I was distracting Louise.
Whichever.
Certainly looking at the patient's history and then the baseline scan, it looks like predominantly nodal disease, is that right? Yeah. So I guess I wouldn't be expecting significant thrombocytopenia, especially in that first treatment block. It's definitely something we look out for and expect after multiple cycles, but after only 3 or 4 cycles, it is a little bit unusual to see that, especially enough to interrupt treatment.
We've had a handful of patients who actually get quite severe thrombocythemia in relation to lutetium PSMA who don't have bone disease. And the interesting thing about those cases is they almost all do very well with treatment, and I wonder whether it's some kind of inherent radiation sensitivity that they've got at don't know what I'm talking about, but germline level.
Germline radiosensitivity.
Yeah, there you go.
We can call that Emmett syndrome.
The Emmett syndrome. But, so I do think some patients show that. We had one patient on therapy. They got 1 dose. Their platelets went right down. It was inexplicable. They came up. We started them again on trial. They're still alive. They're doing extremely well. That was on therapy in 2018.
But it looks like when he progressed in 2022, which is 4 years later, which is quite remarkable, that his pattern of disease is a little bit different.
Yeah. So we go through the transaxles, can see this a little bit clearly, that we now have multifocal bony lesions, which is not the phenotype at baseline. And then when we've restaged them again prior to potential 4th treatment block, again we can see that same phenotype. It's worth noting that for the last restaging, we didn't do an FDG, and part of the rationale for that was that he's had a suitable phenotype at each interval. He's in his late 80s, so we just want to be a little bit we just have to be a little bit careful about what we're putting our older patients through if it's not going to change management.
Michael, or Louise, listening to you say you've seen patients with thrombocytopenia without bone disease reminds us of when we bring these treatments way forward, like lutectomy, for example. A lot of concerns were raised. Well, look, these are fit men who are not going to die of prostate cancer anytime soon. If they do get marrow failure or myelodysplastic disease, we could directly affect their survival. So we were careful about it, but we did see some drops in platelets, James. Or we had one guy, I remember, he was real borderline platelets at entry and dropped a bit, so we didn't give a second cycle. Is this a question for the community as you bring the treatments forward about this direct thrombocytopenia without overwhelming bone metastases? It's not common, is it, or is it a concern for us?
Personally, I think it's not common.
Yep.
I think it's rare. I think it's super interesting. It'd be really nice to know what the phenotype is, or what it is that's causing that kind of response. Whether those patients do have an exceptional response, and what it actually means. I think the myelodysplasia thing. Michael, you've got some pretty good indications from your patients about the level of myelodysplasia. You've had some myelodysplasia.
Well, in this case, he was being considered for further Lutetium-PSMA. Do we need any other clinical information, Louise?
Get back to the thing at hand. Well, I'd love to see his counts.
His counts? Oh, well, here's a graph of his hemoglobin over time. And
Cool.
it's hemoglobin 71.
Now that graph goes back right to before the first lutetium cycle, and the end point is at our consult considering him for this 4th treatment block.
So do we also have platelets?
Oh, platelet. Oh, well, here are his white cells.
Yep.
His white cells are 0.6 and platelets. Oh, yeah. This is platelets over a 5-year period. They're now 39.
So you've got an 86-year-old with pancytopenia, multiple doses of previous lutetium. Perhaps it's what you're worried about, Declan.
Would you retreat him, given the exceptional responses to date?
I think you really want to know why it's pancytopenic, in terms of where that's heading, the speed at which that's going down. It looks pretty fast. I don't have a timeline on that. Is that all 2023, where it's gone from 90 down to 30? Is it very recent?
So he had a bone marrow biopsy, and that actually showed acute myeloid leukemia with a translocation that was thought to be associated with prior therapy and associated with a very poor prognosis. And I think he died within 1 month of that. Do you think the Lutetium-PSMA caused this AML, or do you think it was unrelated?
And what do the oncologists think?
I guess we don't know for sure. I think the risk of MDS, it is generally low, and although the patient did have 9 cycles of lutetium, we've certainly given more than that at Peter Mac. It would be interesting to know what the counts were before the first dose of lutetium, and whether there was already MDS at baseline that has maybe transformed to AML.
Question I've got also for the oncologists is, so we talk about myelodysplasia and the concern when we're bringing it forward, but people get adjuvant chemotherapy as well. And what is the incidence of myelodysplasia and chronic marrow issues with chemo?
It depends on the... it's hard to generalise because it does depend on the agent. I think generally speaking, the taxane drugs we use in prostate cancer, it's not something we typically see, as opposed to some of the chemotherapies we, for example, use in breast cancer, where it's more common. I think in this case, with 9 cycles, I think you'd have to say it's suspicious for being related to Lu-PSMA. The new med physicians can talk to this better than I can, but if the long-term data with lutetium dotatate in neuroendocrine tumours, there is a not insubstantial MDS AML rate. I think, as Declan makes a good point, as lutetium presumably moves forward, it's a consideration. I do wonder about things like the PSMA addition trial that we saw yesterday. 6 cycles have been given to patients who may have very low disease burden after a couple of cycles because of their ADT and their AR pathway inhibitor. What's happening with giving those men big doses of circulating liquid radiation? So I think it's a real consideration.
Yeah, this is an interesting case. Look, in general, we just blame the medical oncologists when we see AML or MDS. We say it was due to the prior chemotherapy. We say that with some confidence. No. But in all seriousness, there probably is incidence of MDS or AML with Lutetium-PSMA that has not yet been defined in the literature, because it has mainly been used in the late stage. In this case, there was unexpected thrombocytopenia, which was prolonged in a patient that had node-only disease, timing with the lutetium. And actually we're writing up this case at the moment because he participated in the therapy trial, and we collected plasma from all these patients for circulating tumour DNA analysis, and Ed Kwan, if he's in the audience up in Vancouver, has received a specimen of this patient and ran his fancy chip analysis and actually found some clonal hematopoiesis at baseline prior to administration of lutetium therapy. So it seemed that this was a patient who was susceptible to MDS, 5 years prior to dying, and then the lutetium treatment maybe has unmasked that. We've now seen, since we've been doing this since 2015, we've seen several cases of MDS. And like our neuroendocrine experience, it's probably mounting. It's going to be a very low incidence. I suspect it's going to be somewhere between 1 to 2%, but not insignificant. And as we bring the treatment back earlier, as Declan was saying, it's something we need to be mindful of. So when you have your patient young and fit who says, look, I don't want ADT, I'm not having any of that, just give me this lutetium. I've seen Peter Mack's image of the year and that's the treatment I'm having. I refuse everything else. You should not do that because we don't know the long-term toxicities yet. That'll be defined over time and in trials.
I think just on a practical point with this case too, so this was a little bit of a tricky consult. It was a really busy day. We hadn't had a chance to have a look at the whole picture before, immediately prior to the consult, and that's when we detected the counts and then found that a bone biopsy had been taken the prior week, but that the patient hadn't actually received that result yet. So we made the decision that we would give the result in our consult because we had to have an explanation for why, with a good imaging phenotype, we wouldn't be able to offer any further lutetium. But I think it's a good reminder to work closely with the multidisciplinary team so that when we're doing tests concurrently, that we're sharing our results and coming up with a combined strategy. So that I think in this situation, that possibly should have been investigated first and might have saved the patient the extra consults with us when we weren't able to treat. But again, in the context of a busy clinic, we don't always get that right, but we just learn from these types of situations and continue to do the best we can for patients.
Louise, next case.
Okay, so case 7, 90-year-old man with MCRPC, chemo-naive. ADT alone for the last 9 years, and then commenced on darolutamide, asymptomatic, ECOG1, home with wife, fully independent, slow rise in PSA. I think we can see that there. So PSA going from 0 to around 80 between 2019 and 2023. PSA currently 84 with a doubling time of 2.6 months and being considered for lutetium.
All right, so you can see the PSMA PET scan FTG. This one windowed well. Very intense uptake in multiple bone metastases. You can see we can play that game, bring it down, SUV max of roughly 151, 150, yeah, so really high, over 100. If you look at that trick I was saying, 15 SUV window versus 30, you can see it holds. It's still very, very intense. And playing with the window, I'd probably say that he's in that 15, 20, probably more on the 20-ish range. Like he's very intense. No FDG avid metastases. I can show you how we contour quickly, if we have a minute for that.
Yeah, show us how you come up with an SUV mean. The magic of quantitative PET. Is that possible? How do you do it?
Guesstimates. We can try this also. We had built this MIM workflow where...
He is the MIM master, James, isn't he?
Suspense. Is this going to work?
Did you learn to use MIM, Declan, when you were doing your sabbatical?
I'm the only surgeon at Peter Mac who has access to MIM, I think. Michael gave me access. We can't afford it normally. Although Danny Mina from Mexico was telling me that they're going to roll out access to MIM for all clinicians, I think, in the hospital. It's beautiful software, isn't it? But we don't get it routinely at Peter Mac. Michael very kindly got me access to a shared license. If too many of them are logged in, I can't get access.
And do you do this on it?
Yeah. Of course, yeah.
All right,
Where do
so
you
I'll
think
just
James
jump
learned it all
in
from?
so I can explain. So you can see right now there's a whole body SUV on CT. It catches everything in the bone, so 150 Hounsfield units, and you can see little holes here. Blows up, it's too fast for me. And basically you contour all of the bone. Once all of that bone is contoured, it'll create about 150 or so lesions, and then use this lower threshold. You can see down here, you can put whatever, it's pre-filled. So we designed this one with 3. So it'll contour within bone everything above 3. And it also does this whole body SUV mean as well. And basically we'll run everything and see do we think it's actually metastases or any spillover from the spleen or the liver or the bladder, for example. So much faster than I could even speak. You can see in this case it's caught probably about 95% of everything. This spots to watch out for. Sometimes it'll catch a little bit of tubarial glands right here. So you can easily wipe that out, 3D brush, make it big. You don't see any mets up here. So you can just want to be careful not to, lacrimal gland that will wipe out. You want to be careful not to erase any, or rub out, I think you say in Australia. Erase, no?
What do you say?
We understand
You say
both.
no rubbers, erasers. Here you go, you can wipe these out, erase them. And when you come down, you can see like this case here, there's some uptake in some ribs, so you can go catch those. Kind of got wiped out because of the, oops. You can catch those, and which have a decent SUV mean. I think we have all of the
Just
bone
keep going down to
lesions.
the bladder.
Yeah, I think this is all bladder. All bladder.
So this is a semi-automated workflow. It essentially captures 95% of the disease very quickly, and then you do a little bit of manual adjustment.
Yep.
And I think in our hands, we can then do some total body tumour parameters really in under 2 or 3 minutes most of the time. And we generally now incorporate this into our standard reporting workflow, so we will often put these quantitative PET parameters in our standard of care reports.
Disease is that. So you
And
can
what
see
is the SUV mean?
Yeah, it was 19.8. So it's pretty
19.8.
close, actually. Just
Could you say so yourself?
you can go, so resume, and then you can catch these other ones. This is bone only, but you could contour also for prostate, nodal, visceral, and then have that SUV total. That's, yeah.
All right. What is the next step? So he's 90, he's asymptomatic. Do we want to do best supportive care, Lutetium-PSMA now, Lutetium-PSMA upon clinical progression, or docetaxel? Wow, he's 90. 90.
I like that 100% for docetaxel.
I
That
know, I
was
was a
pretty
bit
cool.
worried.
This is my geriatrics clinic a few weeks ago.
Arun, do you, or Louise Kostos, do you give 90-year-olds chemotherapy in your practice?
I mean, I guess you never just look at the number, but I'd certainly be reluctant. We normally use, there's sort of online calculators to calculate the chemotherapy risk in the geriatric population, and they're quite useful, and I suspect this man would definitely come out as high risk for chemotherapy toxicity. So I think if Lutetium-PSMA is an option, generally I'd prefer that over chemotherapy in someone who's 90.
And do you want to wait or give it now, given that he's asymptomatic?
I think with a PSA doubling time of less than 3 months and a reasonably high burden of disease, I'd favour treating now rather than waiting.
Yeah, so I think we treated him, and you can see his response after to 3 cycles on post-therapy SPECT-CT images. Prior to cycle 4, he was admitted with symptomatic hypocalcemia with a corrected calcium of 1.9. Shanine, you've written a paper about this. Can you tell us why he's hypocalcemic?
Louise.
Louise.
There's going to be, I was
gonna
Jeremy
wait for
last
Shanine.
time.
Oh my God,
I was gonna
got
wait
a bit
for
of
Shanine.
name.
So hypocalcemia, in our registry at St Vincent's, we certainly looked at hypocalcemia because we did have a number of patients who were admitted to hospital who'd had really good response to Lutetium-PSMA and had subsequently developed hypocalcemia, which was symptomatic and required treatment. And in fact, we got the endocrinologists involved with this, and it looks like it's a local bone effect. It's related to treatment response. It's not related to PTH. It's not related to whether on Xgeva or not, and it's related to the sort of the bone response to the treatment response. And in fact, these patients went on to quite high dose steroid in order to damp the osteoblastic reaction. And it worked really well in those patients, and they went on quite well. We had one patient who kept doing it with every dose, and the other patient did exceptionally well with it, and we've had another patient who settled. In our registry, it's about 5% of patients. You do get two things. You get hungry bone syndrome. So hungry bone syndrome is that kind of hypocalcemia you get in patients with runaway disease, very, very progressive, rapidly progressive disease, and it's related to the disease itself. And then tear phenomena is related to disease response. No one knows, or as far as we're aware, there's really not a good explanation as why you get marked sclerosis as a response in prostate cancer. Super interesting. Don't know if anyone's got a good
So do you check calcium then with like regularly in patients, all patients on Lutetium-PSMA?
We do for the first couple of doses, yeah.
So if it happens, it happens early?
We do.
Yeah.
It's not insignificant, and it tends to be responders. The only unusual thing about this particular case is he doesn't have very high volume disease. Our patients who have been hospitalised with hypocalcemia have had high volume disease with good responses.
Yeah. Would you normally check vitamin D at the beginning or put them on supplements?
We haven't been checking that routinely, no.
Because I think I read your paper after I got the phone call about this case. All your cases had prior denosumab as well, is that correct, Louise?
Not all of them.
Okay.
Well, common side effects of Lutetium-PSMA. This is a less common side effect, but we do see it. We have not been checking calcium routinely in our practice. Maybe we should. Do you think we should, Louise?
In most patients, it's not an issue. You get this incidental hypocalcemia that can be very symptomatic. One of the things I think super interesting is these guys, if they have been hypocalcemic and they do quite well over a period of time, not actually admitted with it, and you follow their CT scan for the 6 doses, they go from having not a lot of sclerosis to almost looking like they've got white marble bone disease. The question is, does that in the long term affect their marrow capability and their marrow, responsiveness to further treatment? Does it limit how much treatment they can actually receive? We don't have that answer.
Maybe we'll switch to the last case just in the interests of time. Our last patient is a 79-year-old pre-carbazitaxel who's had ADT, enzalutamide, docetaxel. He's asymptomatic with a peripheral neuropathy from his chemotherapy. He's ECOG1. He's got a slowly rising PSA over a period, but now it's doubling less than 1 month, so rapidly. His PSA is 262 and he's been referred for Lutetium-PSMA. And here are his scans with the PSMA PET scan on the right and the FDG on the left.
Yeah, so in the interest of time, we'll just say that this is a concordant picture, but we can again see that phenotype of really bulky, intense disease in the retroperitoneal nodal group. And actually when we come down, we can see that there is a problem here on the right-hand side. So we're not seeing that physiologic activity in the right kidney. And coming down, we can see a lot of nodal disease in proximity to that ureter. So I'm not sure, Michael, if you want to go on to the next slide. That just summarises what we've got, but we've got an EGFR of 19.
Yeah, so low kidney function, but very high SUVs. Suitable for Lutetium-PSMA?
I think the image, though, is the previous case, right?
Yes, you're right. That's not the right screenshot.
We'd have...
So if we could just flick back to MIM for the moment, please. We can go back and see.
So just can we have a look at those kidneys? Are they obstructed, or is it hypofunctional, or is it obstructed?
Good looking kidney, it's easily salvageable, isn't it?
Declan.
Yeah, because there's, as we would say, decent meat on that kidney. That's not a kidney that's shriveled up and atrophic, and there's no point trying to rescue it. That looks like a kidney that if we stented it or put in a nephrostomy, and you'll almost certainly get a huge boost in his GFR, and that would be easy to do quickly, I suppose.
We might just switch back to the other screen. Let's just take those PET images as his PET images. You can see his right kidney's obstructed, so I think he's had a nephrostomy in his right kidney after this. Well, James, do you know this case to fill us in?
I saw him much later when we were reconsidering treatment.
So it looks like we treated him, and hesitantly, given the low GFR, but what we did is call our medical physicists in to do some renal dosimetry. So we did 2 time point SPECT CT. Normally we would just image on a single occasion, but here we wanted to know how much radiation was going to those kidneys. So we did a 24 and a 96-hour image, and here we can see some numbers in small print, 1.6 gray to the parotid, and the kidney dose is 0.8 gray on the left and 0.4 gray on the right. What do you think of those numbers?
Can I just ask, was that pre or post stenting? Did you stent him before you gave him the dose?
Correct.
All right, stented, then gave.
Yeah, so very low doses to the kidneys. That gives us confidence that, one, we could proceed to cycle 2 if we need. We don't need to be concerned. We don't need to dose reduce or delay treatment. And you can see we did dose reduce for the first cycle because of that low GFR to 6.8. And he had 4 cycles of treatment despite such a low eGFR.
What does GFR do? 19 to 24?
Yeah, it stayed around the same.
Yeah, okay.
On all bloods.
And he's had quite an exceptional response with, you can see that graph of PSA. We stopped after 4 cycles in this case, and his PSA nadiered at 0.4, which is quite impressive. And here are his blood counts, including his eGFR on the bottom left. And you can see his eGFR sort of hovered around the 25 mark, but did not deteriorate following Lutetium-PSMA. This looks like a pretty good outcome to me.
Happy to see this because a lot of them were actually complicated and a little, difficult. I think the bulk of our patients do quite well. This is a nice, happy one. I saw him when he was at 1.7 just about a month ago, considering to retreat, and he's been, out 79 years old. He's still quite active using a chainsaw, as all Australians do. He wasn't climbing ladders, but he was happy to just continue watching his PSA and wait to treat when the time was ripe.
I might just throw to Liz, we've made this point about ladders a couple of times. Liz, do you want to just sort of go over that a little bit?
Yeah, I think when we make people feel better, they think that they are invincible and that they can climb ladders when they haven't climbed ladders for 10 years. So it's a gentle reminder to remind patients that we don't fix everything, and if they fall off ladders, they still break things. So we haven't worked that one out just yet.
Excellent. Is there another slide? If you want to read more about this case, we published it recently. One of our fellows wrote this up about giving Lutetium-PSMA in the setting of severe renal impairment. I think a message here is that actually the obstruction was caused by nodal disease, and if we can treat the cause of the obstruction, we're not going to make things worse, we're more likely to make things better.
Get a coffee for your urologist and get him down.
Now the problem here is he's had 4 cycles and a long, you can see on that graph, it looks like quite a durable response. I think that graph is actually out to about 15 months. The question is, when should we retreat him with cycle 5? What's the trigger for that?
It's difficult, isn't it? Because you could consider treating at first PSA rise. Obviously, you'd want to know what the volume of disease is. Do you wait for high volume disease before you retreat? If you wait for high volume disease, you can run into problems. It can be harder to get a good response. At the same time, you've got that GFR that's just hovering. So I think it's really tricky.
I think you don't want to wait too long, especially you don't want to wait, what we've looked at is we don't want the peak to go higher than the peak at cycle 1. So you want to treat a bit earlier than that, but yeah, timing is difficult. It depends a lot on what the patient priorities are. How are the previous responses? Did they get exceptional responders, 1-2 cycles? Do they live very far away? It's many considerations.
Yeah, I think the message is to have clear communication amongst the team. This patient's not going to be followed up by nuclear medicine in this sort of 1.5 year period when they're doing well. They're probably going to be seeing their primary medical oncologist. So it's good to communicate a plan and to check PSA regularly. I think every 4 to 6 weeks, not to let the patient go for too long without seeing a doctor. And then for the medical oncologist to re-refer this patient when PSA is definitively rising for consideration of another cycle, and then we can have a chat in the MDT about when to re-challenge.
Which brings us to this question, which is shooting up the league table of popular questions, Michael.
Does Michael come to a 7:30 a.m. MDT? No, that's too early.
Yeah, so it took a few years, as I explained in some conversations this week, but then now he comes at 7:30 on Thursdays because that's where he gets the work. But he does take Tuesday off, doesn't he?
Yeah, but we have the opposite problem. The urologists don't come to our MDT at 9 a.m. because they're in the theatre operating.
That's right.
Do we want to answer any of those questions? Would you re-challenge with an NHA? In the Australian context, crossover therapy from Abbey to Enza is not funded, so it's rarely done. Is that correct, Arun?
Yeah, that's correct.
Yeah, I mean, outside clinical trials, typically not, Michael, yeah.
You can get compassionate, and I have had some patients who, after 6 doses, are left with quite extensive low PSMA expression disease. I have re-challenged those patients with NHA, and it's been quite stunning in some patients. They've lost all of their disease and come back 18 months later with only a couple of spots. So, I think this is a space that needs to be explored. Typically, people will say that second-line NHAs don't work. Well, what happens after Lutetium-PSMA when you've knocked off the PSMA, the AR-resistant clones? I think it's a completely different space. I think there's quite a significant proportion of patients who do have a second, quite prolonged response to NHAs, and it helps you expand the period of time, especially in patients who've failed chemotherapy before, between which they need doses, if you've already used most of your lutetium doses.
Great. Well, we've covered all the cases. So thanks, everyone. Thanks to the panel for joining us.